I'm going to start afresh, like we have not had this session before, so that you can follow. When you log in to your account, you will be welcomed to the home page. The home page looks like this, and for a pharmacist, there is a container where you can switch your pharmacy for the day. For pharmacists that dispense from different locations on different days, it is important to always take note of your assigned pharmacy and make sure you switch your pharmacy before you dispense if you are dispensing from a different pharmacy. For other users that are not pharmacists, you won't find this on your page, but you'll be welcomed with the welcome screen like this. On the left side of the page is a pages menu. When you expand this menu, you will find submenus that are displayed based on the permissions that you have been assigned. Today, we are looking at care registrations and initial evaluation. And we are also going to look at psychosocial support or adherence counseling. When a client is screened at a testing site and the client is confirmed positive, the client is referred for care registration and management. There are 3 types of referral. One for HIV care registration and management, which is done when a client is HIV positive. Even if that same client has other STIs and TB, just the HIV referral will be done. We have the TB referral, which is done when a client does not have HIV, but has TB. And then we have the other referrals that is done when a client has other STIs or viral hepatitis, or when a client is on a risk reduction plan to be placed on PrEP and PEP. For the clinical care nurse or the clinical care team, when you come to care registrations and initial evaluation submenu, you will find a list of functionalities. You have a link to view HIV care referrals. You have a link to view TB care referrals. You have a link to view other care referrals. These 3 links gives you the list of all the referrals that have been done from various testing sites across the country that are not yet registered in care. Once a client is registered in care, the client will no longer be on the list of view. When you want to view all clients that are in care, we have links to do that. We have links to look at registered clients for HIV, registered clients for tuberculosis, and registered clients for others. In the event when a client is in front of you and you can't find the client's unique ID on the list of referred clients, you want to check the list of registered clients if the client has been registered by someone else or from another site. If you don't find the unique ID on the list of registered clients, then it means one of 3 things. Either the testing site did not do the electronic referral on the system, or the testing site did not create an account for the client on the system, or the client has an account on the system, but the screenings were not recorded on the system. So once you don't find a unique ID, you have to contact the testing site that the client has said they're coming from. If you have a paper referral, you might want to use the paper for that day and sort it out later so that you don't waste the client's time. And if it is a matter of not referral, if you have the referrals permission, you can go straight to do the electronic referrals yourself and get the work done or you call the health center to do it and get the work done. So it depends on what you want to do. But those are the reasons why a client's account might not be found when you want to register into care. Once you have seen the client's unique ID on the list, it is now time to register the client into care. There are 4 types of registrations. We have registration of exposed infants. Exposed infants are not referred. You will register them using the Exposed Infant Care Registration form. When you come to this form, you fill out the form, enter the mother's unique ID if the mother is a positive client in care, and the infant's unique ID. And then when you save this form, it will generate other files for the exposed infant. We also have the second type of registration, which is HIV Care Registration. This will ask you for the unique ID of the referred client you want to register into care. Once you put in the ID, you will get a form that will ask you for the date of registration, and then you submit that form for the system to generate initial and clinical evaluation forms for the client. Also, we have the third type of registration, which is Tbk Registration. The Tbk Registration is a little different from the HIV Care Registration. If you are registering a client for tuberculosis care and treatment, all you need to do is to put in the ID of a referred client, and then the system now doesn't generate initial evaluation forms, but transfers all of the records from the health center for clinical management. And when you go to clinical management and you enter that unique ID, the system is going to give you all the case notes plus additional TB forms. And we're going to look at that in a while. We have the fourth type of care registration, which is other care registration. So this also acts similar to the Tbk registration, where the system transfers the files from the health center. The health center still retains a copy for future use or when they need to update new screenings if that client comes back to the health center. But the clinical care team will have access to all the files to do further screenings and to record new treatments for other STIs and viral hepatitis, and also for PrEP and PEP clients. When a client is registered, there are 3 types of initial and clinical evaluation. If the registered client is an adult, or is a pregnant client, or an adolescent client, the adult, pregnant, and adolescent initial and clinical evaluation link will give you the form to enter the unique ID and retrieve all of the generated files for the client to record all of the baseline and initial evaluation for the client. If the client who is registered into care is a pediatric client, then you will have the pediatric initial and clinical evaluation forms generated, and you will retrieve that form by coming to pediatric initial and clinical evaluation link. If the registered client is an exposed infant, what you will do is to go to exposed infant evaluation, enter the infant's unique ID, and retrieve the evaluation forms. So these are the functionalities of the care registration and initial evaluation. Let's look at the workflow. There are several workflows and pathways to this. Under the care registrations and initial evaluation functionalities, we have links to view care referrals for HIV, view Tbk referrals, view other care referrals. We have link to register exposed infants into care, to register HIV clients who are referred, register referred TB clients, and register other clients for other purposes. We also have the link to retrieve the generated files for a registered client. If the client is an adult, an adolescent, or a pregnant client, we have links that will retrieve the adult, pregnant, and adolescent initial and clinical evaluation forms for the client when the unique ID is entered. If the client is pediatric, we have pediatric initial and clinical evaluation. View HIV care referrals, view Tb care referral, view other care referral depends on the referrals done from the health centers. Exposed infants care registration does not depend on anything. You do the registration there without waiting for any external job to be done. HIV care registration, Tb care registration, and other care registration depends on the referrals that were successfully sent on the system. Adult, pediatric, adolescent initial and clinical evaluation depends on the HIV care registration of an adult client. Pediatric initial and clinical evaluation depends on HIV care registration of a pediatric client. Exposed infant evaluation depends on exposed infant care registration. The registered clients HIV, registered clients TB, and registered clients others depends on HIV care registration, Tb care registration, and other care registrations. We now have the process flow for HIV care registration of referred clients. So for all clients that are referred for HIV registration, you want to view the care referrals, find out if the unique ID exists amongst the unique IDs of those who are referred but not yet in care. Then you view, you register the clients by using the HIV care registration link. And then you go to the initial and clinical evaluation. If the client is an adult, pregnant, or adolescent, you want to use the adult, pregnant, and adolescent initial and clinical evaluation. And if the client is pediatric, you want to use pediatric initial and clinical evaluation. Now, the process flow for the registration of exposed infants. There's a typo here. So the exposed infant care registration first, then you go to exposed infant evaluation. The evaluation forms for exposed infants consist of the enrollment or baseline information, the screenings, and the immunizations. The process flow for Tb care registration is to view the Tb care referrals and you register the client into care. The process flow for other care registration is to view the other care referrals and you do other and register the care referrals into care. I'm going to change this also. So if you want to view all registered clients, you look at registered clients HIV, registered client TB, and registered client others. To get the clients to clinical management, the process flow is like this. We register the client into care, do the initial and clinical evaluation, send the client for psychosocial support or adherence counseling. If the session starts and the client is determined to be ready or ready to adhere to medication, then send the client for clinical management assessment. If the client is not ready, you do an adherence strategy work plan and then send the client for clinical management appointments. For TB, it is just from registration to care. And for other STIs, it is from registration to care. Any question before I go further?
I'm just wondering, is this last part here where you have care registration and initial evaluation, is it spelled out like this in the manual?
I mean, if it's spelled like that on the site?
No, what I'm saying is that you see when you go into the page and you click these tabs, these are what will happen from each tab. Yes. So I'm just saying, I'm just asking, is it spelled out like this in the manual.
Yes, it is spelled out like this.
Okay then, thank you.
Yeah. So I already uploaded this to your page, so you can use this as a reference. The links are named exactly as it is stated here. So we will look at today's case scenario. Last week, we did the training for general population screenings, and we had two cases that we discussed. We had Grace, who is an 11-year-old girl who was brought in by her mother to A&E because she was raped by her neighbor's son. She has also been abused physically by her parents because of her perceived disobedience. She admits to the nurse that she has been sexually active since 9, and the routine blood screenings done revealed that she has syphilis, genital warts, and she's HIV positive. So Grace has been referred for care registration and management. She was referred from Site X, and she was confirmed HIV positive on the 31st day of January 2022 with reactive VDRL or TPHA, and the titer value is 1 in 64. We have the second case we are going to look at. Is a case of Josette. Josette is a 15-year-old Form 5 student, and after not seeing her period for 2 months, she presents at her first she presents to the health center, and her test revealed that she was pregnant. She has no history of chronic medical illnesses. She has a family history of diabetes and hypertension. She has no surgical history or medications. She presents with mild, non-productive cough. Her HIV and syphilis screenings return non-reactive. Josette breaks up with her partner and baby father, Philip, during the pregnancy and has a new boyfriend named John. After 3 months, that is gestation age 26, they go for screenings since they have become sexually intimate. She now presents with mild rash on the palm of her hands and is a bit more tired at the end of the day. Her serology results showed that she is HIV positive. She has RPR or VDRL reactive with 1 in 16 titer, and other results include HCLV1 negative, TPHA reactive, hepatitis B surface antigen result was positive. She has hemoglobin value of HB value of 9.8. Her HB electrophoresis shows that she is AA, and her rhesus is null. Her vaginal swab is positive for bacterial vaginosis, and endocervical swab is negative. Her 25-year-old partner, John, is also HIV positive and syphilis positive with an RPR reactive value, titer value of 1 in 128 and positive for herpes. On her ultrasound examination, it was revealed that the fetus had a gestation age of 25 weeks and 4 days, a fetal heartbeat of 40 beats per minute with no congenital defect. Josette has had her entire course of immunizations at birth. She is treated for syphilis with 3 weekly injections of penicillin. What we are going to focus on today is her PMTCT treatment. She is immediately started on antiretroviral therapy, giving the standard single tablet combination of TDF, FTC, EFV, and as a policy for all antenatal clients, the clinic tested Josette for HIV drug resistance with a genotype test. Our clinical team on this call today will decide the treatment outcome, including her Cd4 and viral load values, and plus we are going to edit the PMTCT intervention given. She later had a vaginal delivery of a 7-pound baby boy at 39 weeks gestation. The clinical team will also discuss the baby's outcome, the intervention, the screenings, and immunization. When the infant was 7 weeks old, Josette brought him to the clinic for his first infant checkup. He was asymptomatic. There, his AZT medication was stopped. He was continued on Septrin and given the second DNA PCR test. Josette continued her HIV care at the clinic. Her HIV drug resistance test results returned, showing that she has a K65R and K103N mutations, which made her first-line regimen inferior. She was subsequently switched to second-line AZT3TC and I will not bite my tongue. Her follow-up SCI screenings showed that she was positive for chlamydia, and she revealed that she had made up with her child's father, but was still seeing John. Given her risk behavior, she was given a risk reduction plan. She listed her baby's father as a contact for provider referral screenings and testing. So this case has a lot of typos, and we are going to look at it. We will start with Grace. So I will log in and we will look at Grace referral. So the first thing I want to do in this case is to go to look at the list of care referrals. So I want to register Grace into care. And I'm going to use this unique ID. This is one of Grace that is referred, G123. Now Grace is sitting in front of me, and after viewing the referral list, and she's on the list, I will go to Hiv Care Registration. I will put in the unique ID, and I will get the registration form. I'll put in the date of care registration, which is 9th day of February, 2022, and I will register Grace into care. Now Grace is registered. The system has generated all of her initial evaluation forms. I will go back to my pages menu, go back to my care registration and initial evaluation submenu, and I will click on, because Grace is pediatric 11, I will click on pediatric initial and clinical evaluation. If you go to adult, you won't find her record. So when I click on this, I will get all of the forms generated for her initial and clinical evaluation. Now, there were recommendations yesterday to add the name or the type of primary caregivers and type of secondary, so that when we put in the name, we can see if the person is a biological parent or a family friend or a relative or a foster parent or any other legal guardian, or any other guardian that is not legal, or a social worker. So this will cover the list of the different types of caregiver that we'll have. So the maternal treatment during pregnancy, we do not have this information. Grace has a mother who is not HIV positive. So all of this information is not part of Grace's history. Her primary caregiver is, I'll give her mother a name, Hannah. So let's say Hannah Paul. And this is a biological parent. Her secondary caregiver is, let's say, her grandmom, which is Mary Paul. And this type is family relative. The address of her primary caregiver, which is her mom, let's say her mom lives at Hope Street. And the address of secondary caregiver, we are going to assume that the grandmom lives at the same address. Did the caregiver agree to home visit? We are going to say no. Telephone number of caregiver, she doesn't want to give us that also. The mode of transmission, unknown for now. The mode of delivery when she was born was vaginal. Her gestation age when she was born. These are optional because Grace was not an exposed infant. But if you have the information from her antenatal card, if her mom brings it in, you can put that in here. So when she was born at 40 weeks gestation. And the duration of membrane rupture, let's assume that it wasn't on her card. The date of final HIV diagnosis, the case scenario said she was confirmed positive on January 31st. (2022). The date of enrollment into care, or the type of test, was an antibody test, and the date of enrollment into care is today. So the date started ARV, she has not started yet, and the date of status disclosure to child. So let's assume that she has just been told today about her HIV status. And we assume that she doesn't really understand. Is the child's mother alive? Yes, the mother is alive, and the father's HIV status is unknown. The address of father, so the father lives at and the father's telephone number was given. And then we are going to save this. So we have collected the pediatric enrollment information for Grace with all of the information that we have. If anything changes in the future, or if there's any field we did not fill in and later get that information, we can come back to this initial evaluation and fill it in. When she's placed on ARTS, you can come back and put the date started at on this form. The clinical stage. Grace has, we are going to assume that Grace is here today with advanced symptoms. And so she's going to be in stage 3. So the date of stage 3 diagnosis is this. And then we're going to save this. So now we have staged her clinically. On the care card, when she goes for clinical management, there is a different clinical staging form that checks symptom by symptom. So this is just the first initial assumption that is going to be filled on the form. Immunizations. So the mother did not come in at this visit with her immunization card, and we don't know what she has been given. So during her next visit, we will have her immunization record and we'll fill them in one after the other. For the viral load, there was also a recommendation yesterday to put the date of request and then the date of the test. So I now have that there. So we are requesting that she goes for a viral load test today. We don't have the results and we don't know the date she will go, but we put the date of request and we'll submit this. So this wants us to put the date. So what you will do in an event when a field is compulsory, you put the present day and assume that she's going today. And when the result returns, you put the date on the result. So if she goes today, then you don't need to update this date. But when the result returns, and let's assume that she goes tomorrow or 12, you're putting the result as the date the sample was drawn. The Cd4 count also has the same change. You want to put the date of request, which is today, and then we don't have any of the Cd4 values, so we don't know the date of first Cd4 test yet. We don't know the date of first Cd4 count less than 350, and we don't know the date of first CD count less than 200. But when her result returns, we will assume that her Cd4 count will be lower than all of this. So submit. So this wants a date, and I'll put this here as a date of request. And when it returns, I will put the date that the sample was drawn. So you are done with the initial evaluation for Grace. The next thing you want to do for Grace now is to send her to the adherence counselor or a social worker. When she arrives there, whoever is doing that job will have the psychosocial support or adherence counseling permission. When you expand that submenu, you will find links to schedule counseling appointments, to look at the pending counseling appointments, to start the encounter, and to go through the past counseling encounter for the clients. So we want to give an appointment for today. Her unique ID was G123. And we are sending her for adherence readiness assessment. So like I said yesterday, there are 3 types of adherence sessions. We have adherence readiness assessment, we have adherence strategy work plan, and we have adherence follow-up assessment. We use the readiness assessment to do the initial evaluation of the client, after their first visit and until they are ready to be placed on ART. We use the adherence strategy work plan if the result of the adherence readiness assessment says that the client is not yet ready to be adherent to the medications. Then you use the adherence follow-up assessment at every clinical management visit for clients who are on any medication, and you want to see if they miss doses and if they are non-adherent before they see the care coordinator for another set of prescriptions. So Grace has been given an appointment for the psychosocial support and adherence counseling. You come back to the tab or to the menu, psychosocial support and adherence counseling, and you click on Start Counseling Encounter. You enter a unique ID, G123, and then Get Form. The system is going to give you forms based on the type of session that you selected when you were given this appointment. On the form, it gives a unique ID and the current age of the client. It also tells the counselor when the next Cd4 test is due and when the next viral load test is due. Now, the system automatically calculates 3 days from the date of the last recorded test. So recall that we put in the date of first test as the current date today, and the system automatically puts 3 months ahead from this date, with the assumption that the client is going today. When the results return and you update the dates, the system will update the flag to give you the new date that is expected. So in the event where the country still use the rule of Cd4 test every 3 months and viral load every 6 months, you can go by the dates. In the events where you are not doing the 3 months test and 6 month test, then you can ignore the dates, but use it as a reminder when you have non-adherent clients that you need to do a test or the last test is long overdue. So when you come to the form, there are questions to be answered. These questions, when you ask them, there are questions that are to be answered by the client if the client is an adult, and the caregiver if the client is a child. So how many sessions of pre-treatment counseling did this client attend? This is the first session. Is the client's treatment literacy sufficient? Let's say her mother is educated and her mom understands all you are going to say. Does the client have misconceptions about ARVs? Let's say yes, the mother has misconceptions and the mother feels that the ARV, so she says ARVs are like chemotherapy. So you counsel on the misconceptions. Has the client disclosed his or her status, and if yes, to whom? Let's say yes, the mother has disclosed and disclosed to the grandmother. You can put in the name of the grandmother if you have that. Is this person supportive? So we'll say yes, she's supportive, and so there is no reason. You put in the reason if the person was not supportive, and you put in the assumed reason or why you think the person is not supportive. Has the partner been tested for HIV? So in this case, we'll assume yes, that her mom has been tested, but not all her partners have been tested. When you have partner of a child and the child is an index child, which means that the child was not exposed and is the first person in the family who is HIV positive. The partners of the child are the other siblings, the mom, if the mom is not available, the dad, and if she has sexual partners or injection drug partners. But under normal circumstances, we assume that most of the time, the children will not have sexual partners and injection drug partners, but in this case, she has one. So the answer now is not going to be yes, because let's assume that only her mother has been screened. She has younger ones who have not been screened, and her sexual partner and the person who raped her has not been screened, so we'll say no. Is the partner taking ART if living with HIV? In this case, it is not applicable because we don't have partners tested yet. Does the client have children? And this is not applicable because the client is a child. Does the client have a treatment assistant? We'll say yes, and the treatment assistant is mother. Did the treatment assistant take part in the pre-treatment adherence session? Yes. Does the client wish to be visited at home? We'll say no. And if the client wishes to be visited, we'll put the location and the description. How will you describe the client's mental state? So at this point, you are looking at the mental state of both the child and the mother, but mostly of the caregiver. So we'll say she looks anxious. Does the client fear discrimination or violence at home or in the community? And then we'll say the mother says she fears that the child will be rejected when she gets back to school. And so we'll say yes. Or if her status is disclosed in school, that she feels the child will be rejected. So we'll say yes, the caregiver is afraid of discrimination and violence. So at this point, if there are support groups in the country, you want to refer for support groups or to a psychologist or anywhere they can get advanced help. Who does the client go to for support at home or in the community? Let's assume that for now they have no other support outside of the primary and secondary caregiver. Does the client come to clinic on his or her appointment date? So this is our first appointment, and we don't know if they're just coming for the first time and if they will continue coming. Has the client been adherent to other medications in the past? We asked the mom if she has always remembered to give her child medication in the past, and she said yes all of the time. She doesn't forget that. So have we planned a drug timetable with the client? We'll say no. Is the client a member of a care and support group? If yes, we'll put in the location of that group, but now we'll say no. The client is not addicted to any substance, we'll say not applicable. And does the client feel confident about taking the medication or giving children medications every day for the rest of life? She said she's not sure if she will remember every day for an extended period of time. So we'll say no, she's not confident. Who else takes care of the child other than the caregiver present? So we'll say grandmother. And has the caregiver been trained? No, the grandmother has not come to the clinic before. Has the client had any challenges taking other medications every day at the same time? We'll say for now, no, they've not had challenge because they've only had short-term medications. Does clients know the names of the medications to be taken at the time? And at this time, you would have told them the names, the side effects, and the times that the medication should be taken. And if the mom can accurately remember and say it back to you or describe them for you when she holds the medications, then the client knows the names. But at this point, we'll say no, the mom cannot. She keeps getting confused about the medications, even though they were labeled. So you have a labeled sample in the office that you use to train them and see their readiness. Does the client know the side effects of these ARVs? So you counsel on side effect management. You ask them if they understand it. Yes, they know the side effects. Does the client know the consequences of not taking the medications every day for life? And you do the counsel on long life adherence. So they know the consequence now. And is the client on other medications other than the ones prescribed by the doctor? So you want to ask the mom if she gives her child any traditional or herbal medicines, and she says no. And you want to look at the assessment of client's readiness to start ARTS. We want to say this client requires more preparation and counseling. So the questions and concern is that the mother said needs time to digest the information and settle into the reality. So she said she is not sure she is mentally ready for the treatment. So other issues and notes. Mother needs psychological support. Has she looks anxious and depressed. So we have put in information, and so you're going to fill in the information based on the information you have from the client in front of you, and then you save this. So because we have said that the client requires more preparation and counseling, it means that when this client walks in for clinical management, the care coordinator will see on the page that the report says that the client is not ready. So they will decide if they want to still prescribe the medications or wait until the client is ready. Because this client is not ready and the adherence counselor wants to help the client get ready as soon as possible, you will give the client another appointment. I'll put in the unique ID. And this time, the appointment you give for people who are not ready, but you want to prepare them to be ready, is an adherence strategy work plan. So after the appointment, you can do the appointment on the same day, on a different day. Just schedule the appointment so that the system generates the form for when you need to start the session. Then I'll come back to start counseling encounter. I'll enter the ID and I will get form. Now, all this form is asking is to fill in information about what you are going to do to make the client ready. Recommend attendance at a HIV basic seminar. If there is one in the country, yes. If there is one and you are not recommending, no. And if there is none, none. If you have attendance of, if you have adherence basic seminar in the country, you want to recommend, yes. If you don't want to recommend, no. And if there is none, none. You discuss with the patient the preferred adherence strategy. What can help them to be adherent if they are to start the medication? Do they want a treatment partner or they want self-managed adherence? And let's say the mother said when she starts, she'll want to go with self-managed adherence. Now we want to conduct a 1-week practice trial to simulate the commitments and attention necessary for the medications. So you can either prescribe multivitamins, Septrin, whatever it is that you can give at the frequency of the intended ARV. And if you're not using any of this, none, and you put the medication, maybe I want to use calcium supplements, or I'm going to use vitamin C. But I want to give the frequency of the medication with the same frequency and prescription of the ARV, and they try it for a week or two and see if they remember and if they have developed better strategies for adherence. And now we are going to select reassess on a later date and then save. So you can give them an appointment to come back for another readiness assessment in the next 1 week or 2 weeks so that they can get into care as early as possible. Once this is done and they go back to the nurse, they can move from here for clinical management for the clinical care coordinator to do a full clinical assessment and decide what the next course of action is. But we're going to look at clinical management starting Monday next week. So the job for this client is done for today's agenda. So we have seen how we register a client into care, do the initial evaluation, and send the client for readiness assessment. We looked at the pediatric clients. If the client was not pediatric, the forms that are generated will be slightly different. Let's look at the HIV Care Referrals. We have a second case of Josette. We're going to put Josette as an adolescent. She's 15 years old. And she's pregnant. So Josette has multiple problems. She has both HIV, she has syphilis, she has hepatitis, she has a golden blood type, and her HB is low, and she's pregnant. We're going to take an ID for Josette, J1, 123, and we're going to register Josette into care. Now we'll put in the date of registration and we'll register. So based on the case scenario, she was confirmed positive on February 2nd, 2022. So we are going to go to this time, because she's adolescent, we are going to adult, pregnant, and adolescent initial and clinical evaluation. So the unique ID was J123, and we'll get form. Now her form is not loading, and this is going to be one of the consequences of missing data or when information is not accurately filled in for Josette. So there's a reason why her page has refused to load, and that might just be from her data. So we're going to use another client, and then I will go to correct her data entry. So these are the effects of when I say data has to be complete and effective, because if a critical data is missing, then it stops further data from loading on that client. So let's go back to select a client who doesn't have missing records. So I will use somebody who is, let's use Sam. And I will do the initial and clinical evaluation for this client. So we'll assume that this person is the Josette we are talking about, and we are going to do everything we are going to do for Josette on this client. So this loaded because whoever entered this information has entered it completely and correctly. Now, you will see that the forms generated for initial evaluation for a client that is not pediatric or exposed infant is different from what we saw at the pediatric clients. The clinical stage, the Cd4 and the viral load remains the same, but the enrollment information and the baseline information forms are different. For the enrollment information, we have the date confirmed positive has the case scenario said was confirmed positive on the 2nd of February, 2022. The date of enrollment is 9th of February, 2022. And the age of enrollment is 42. So we're assuming that this particular record, we are going to use the story of Josette, of Josette to fill this. Although the scenario said it is a 15-year-old female, this record we are using for the sample is a 42-year-old male. So apart from these information that are different, we are going to follow the story of treatment and assume that we are filling information for a male, and we are going to go ahead with what the story says. So you submit this. The baseline information. The date started at. This client is not yet on ART, is coming in today for the first time. Initial weight. So let's say her initial weight is, the scenario did not give us her weight, so I'll just assume she's 200 pounds. And clinical stage is stage 2. Her treatment supporter or medication pickup, if ill, she listed John, her current boyfriend. And the relationship is, let's say, baby father. No, he's not the baby father. According to the story, he is in a relationship. So just put boyfriend. Home-based care provider, she doesn't have one yet. And she said she doesn't know if she has any drug allergies. So we are going to submit this form. So no known allergies. So her clinical stage here, we said she is in stage 2, and the date of first stage 1 or 2 diagnosis is today. So based on the symptoms, the clinical care coordinator or the doctor who sees her is going to stage her properly. So this is the initial assumed stage. And as Cd4 information, we are going to request a test today, and we're going to assume she's going to do it today. And when the result returns, we're going to update the date to the date that the sample was taken. Viral load information, we are not requesting today. We will ask her to come back later on. Because I want to use this to demonstrate what the system does if a request is not made at the first visit. So we have done the initial evaluation. So we can go through the process now of sending for psychosocial and adherence counseling, and then seeing if the client is ready, and then sending for clinical management. So I won't repeat that process because it is exactly the same as the process for the pediatric clients. But there's one last type of registration, which is the registration for exposed infants. So this same Josette from the scenario had a baby boy. So we're going to register that child. So the scenario says that she had a vaginal delivery of a 7-pound baby boy at 39 weeks gestation. So we are going to create an account for an exposed infant today. So the infant's first name, we're going to give her baby a name, David. And the infant doesn't have a middle name, and the last name for the infant is Philip. The infant was born on, let's say, on the 3rd day of February, 2022. The mother's ID, so we'll use Josette's ID, J123, and the infant's ID, we'll put J123, David. The health district, we'll select any health district on the list that the client belongs to and the parish of the health district. Then we also put in the sex of the child, which is male, and the birth weight was 7 pounds. The system converts it to kilogram. The length of the child at birth was not given, so I will assume the child was 47 centimeters when the child was born. So you put just the number so that the system can convert it to meters. And then the type of feeding was replacement feed, and we'll register the baby as an exposed infant. Once an exposed infant is registered, then you come to exposed infant initial or exposed infant care evaluation. So we have exposed infant evaluation. And then you put in the ID, J123, David. The exposed infant evaluation is similar to the pediatric evaluation with the exception of the screenings. So maternal treatment during pregnancy, the scenario said she was given TDF, FTC, EFV. During labor, she was on this throughout, she was on PMTCT, and the child was born and was given AZT. The age of child at enrollment, So the child is being enrolled today. The child is 1 week old. The name of primary caregiver of the child is, so we assume that Josette cannot really take care of the child. So she's going to be a secondary caregiver, and Josette's mother, who is called Martha, is going to be the primary caregiver of the child and is going to be a family relative. And the secondary caregiver will be Josette herself. And the type is biological parent. The address of the primary caregiver, let's say the primary caregiver lives at Kingstown, and the secondary caregiver lives at the same address. The grandmom, which is Josette's mom, agreed to home visit and gave a telephone number. The child is not yet positive, so there is no mode of transmission. The child was born via vaginal delivery, and the gestation age at birth was 39 weeks. The duration of membrane rupture was very prolonged, so there's now a risk, there's another risk, so we'll make it prolonged, 16 hours and 30 minutes. The date of final HIV diagnosis does not apply to this infant. There is no test yet, and the child has not been enrolled into care as a positive client. So you can leave all of this down and come to the address of father. So let's say Josette's father lives at Zion Hill in St. Vincent there, and his telephone number was given. And then we'll save this. So you have collected the exposed infant enrollment information. The information is retained, and so in the future, if you need to update any field, all you need to do is to select that field and click on save, and it updates just what you want to update. So the exposed infant screening, there was a recommendation that we put the age at test. So although the system calculates it automatically, I put it here to make sure everybody, to make it less confusing. So the age at test now is 1 week, and this child is doing the first test. So the countries will have their guidelines to when the first test, second test, third, fourth is done. But we'll allow the system, allow any time for those who will be late, and you just use this for reporting to see the difference in time if people are really doing the first test between 0 to 2 days old, or they're doing it later down the line. The type of test is PCR, and we'll assume that we have the result, which is negative. And then we are going to save this. We have collected the first test. The next screening that will be done for this child, you come back to the exposed infant evaluation and you record values for test 2, the age, the date, the type, the result. For immunizations, so any vaccine or any immunization the child is given is going to be recorded here from birth and going forward. So this is all the functionalities that we have under care registration, initial evaluation, and adherence readiness assessment. But before we go to take questions, I am going to show you, we only discuss HIV care registrations. So I would show you what happens with other care registrations that is not HIV. If you come back to care registration and initial evaluation, and you look at TB referrals, we have a unique ID on the list. So let's assume that this Moses Gabriel is sitting in front of us and he has been referred. He was positive. He has symptoms for TB. Possibly he's, maybe his skin test had a very large induration. They have not done any other tests apart from the skin test. The chest x-ray also showed something, and then they referred the client for TB management. So at the TB clinic, the further evaluation will be done. So you take the unique ID from the referrals for the client who is sitting in front of you, and then you go to Tb Care Registration. Enter the unique ID and get registration form. It is the same registration process, apart from the fact that this does not have an initial evaluation form. When you register this client for TB, you get a success message and the job is for registration for TB is done. No initial evaluation, no category of you are going to adult or pediatric. It's just one method, and the clinical care coordinator will see the age on the care card. I'll show you that, although that is not part of today's agenda. The clinical care, the doctor will have a clinical management permission and will see this clinical management menu. When you expand that, they will see TB care card. When you click on TB care card now and enter that unique ID for a registered TB client, then you will get the care card for the TB. On this care card, it also flags if there is a record of HIV screening for the TB client and if there is a record of syphilis screening for the TB client. If this was not done and TB was just the focus at the health center, the doctor can decide based on symptoms or regulations or what is required to do this test, but the system keeps flags whether the tests have been done or not. Now, all of the records from the health center is automatically added to the file. The personal information, the risk factors, the comorbid information, the HIV screening result, if he has one and there is none, the TB screening, and then the syphilis screening. So you can look at the TB screening that was done before the referral was made and the sites that the test was done in. Then if there were other screenings, they will be listed here, but this client has only done that mantle test. And then if there were contacts listed. All of these first line of tabs are all information that the health center recorded. Going forward, you can decide to do more risk factor information or HIV screenings and record them here at the management center since the client has been referred. But where the management of TB will start is from registration information. We're going to look at this in detail next week. This is not today's agenda, but I want to show you that the HIV care process is different from someone with TB without HIV. So this gives the baseline registration for TB, which is done here, the symptomatic checklist for TB, so the diagnosis and criteria. So even if this person was referred, the final diagnosis of the TB will be done by the doctor and will check what type of tuberculosis it is and what the diagnosis criteria is. If it's presumptive, it is bacteriologically confirmed or clinically diagnosed tuberculosis. And then you'll do the drug resistance testing, if any, and then the treatment plan will come in here, and all the treatments done is going to be here. The treatment monitoring will be here. If there's any treatment monitoring, any treatment that has been done, you see it here and you can monitor the treatment, the adverse effects of the drugs, and the symptom checklist. So we are going to look at all of these next week, but this is how the TB clinic runs. Now, for most countries, we know that HIV and TB are done together, but then you have to see which clients have TB but have no HIV. Those ones will have just TB forms. Clients with HIV has both TB, syphilis, or every other thing. They have access to all the care management for when they have opportunistic infections and other things. So I will pause for questions and then we will continue. Any questions?
Not at this time, Mildred.
Okay. So I will assume that we all understand everything today, and then we'll go into breakout rooms. What we will do in the breakout rooms is to use the case scenario, right? You can use exactly this one to follow a story. You can make up one to try out, but we want to look at case one. You want to go through the care referrals list and pick anything on the list. You want to pick one adult, one pediatric, and try out what we did for care registration and initial evaluation. In the event where this list is exhausted and there is no more clients to be used on the list, anyone who was part of general population can create new accounts and quickly register HIV screenings and refer, so you can have more clients to work with. I will jump into each breakout room to answer questions and see how it's going. So one person would share the screen and everybody discuss and enter the record. The hands-on is going to help the understanding better. So any question before we go? I have in the chat the case scenario and the workflow.
Yes, Mildred, not really a question, but I just need a little bit of explanation. Okay. I think we normally have problem, like when we move from this screen to the sharing screen.
Yeah.
And how do we maneuver the cases?
So you can,
those things do take some time. So you find sometimes by the time people get themselves organized, time gone.
Okay, so I will come into each room at the very beginning to help you with that.
Okay. Mildred, in the previous groups, what we have done, one person does screen share and the other person brings up the case-based surveillance system. So we can read while we plug in the information. So it means that two persons will be actively engaged and the others also will be helping as we go along to fill in the necessary spaces. But I would like to see what you would suggest when you come into the groups. Thank you.
All right, thank you. Okay, so I will do the sessions now.
No break?
Okay, so so let's go on a 10-minute break, and then when we come back, we will be in breakout rooms.
Thank you.
Okay.
Some other countries, it may not be test and treat, it may be test and wait. So that will determine how we go forward. So that's it for me. I'm quite sure my colleagues may have other things to say.
Yeah, thank you.
For me, this one is a first for me. I'm familiar with data recording, which we did manually, but not in this format. However, with this format, it is not difficult. It's just once you get to the hang of it, it's okay, as we learn by trial and error, which is how we learn. However, is there any, if you input a wrong numeral, or you want to, how do I say this? You cannot clear it easily and put in the correct information. There's nothing to clear or type back or space back, and then put in the correct information. I don't see that there. Also, if you are trying to, I just had it, just disappeared. Well, that's one thing, trying to clear something so you don't make a mistake or make an error, instead of having to dump the file and start all over again. I think something like that should be included where you can clear something. However, I'm saying this is like when you're imputing the data, if you're one letter off, a typo or a number off, how do you clear it? What do you do if it does not allow you to clear it?
Okay. It will always allow you to clear, but in the events where you are typing in names and you already move to the next tab, it will require you to finish filling the next tab you are in before you go back to clear the errors. So if you have errors on, let's say for instance, you put in first name and then you are filling in the last name when you realize the first name was wrong. Yes. You have to finish filling last name before you go back to correct first name. As long as you don't fill in that last name, you can't move back to first.
Okay, what if, and my next question is dates. So if you put in the wrong date, however, you're trying to fix it and you cannot, what do? Do you continue?
Yeah, if you put in the wrong date, especially date of birth or date of record, you can't change those, only your supervisor. So you send your supervisor a message and tell them what you have put in wrong. And the supervisor's dashboard allows supervisors to change those security information.
Okay, understood, got that. So there are measures put in place, safety stuff that you can correct the errors. Understood, wonderful. Those were my two of my main concerns, because when we were inputting the data, a wrong date was put in, or we were trying to go back to fix something that we realized we can't take it out. So knowing that, then okay, all right, sounds good. So you
always call your supervisor with a unique ID that you make the error, and then the supervisor will update that.
Understood. It's like me managing a restaurant and the cashier made a mistake. I now come in, turn the key to a certain thing with a master key and correct it, and you can go on.
Yes.
Got it. Okay, thank you. But all in all, it is it's very unique. The system is very unique, detailed. And last night I was trying. I made a lot of mistakes last night. Trying to do something. I just say, well, that's how you learn. It's okay. And but I like it. And once I get the hang of it, or once we get the hang of it, we will be okay. But it's very unique and it's detailed to the point. It's just that let's just keep our fingers crossed that the clients can sit for, if it's 10, 15 minutes to have it done, or we take all the information and then we upload it. Yeah.
But you see, one of the things about paper and timing of clients, it's just that, like if you go to most of this first world, they've gotten to a point where they put appointments and they time appointments to maybe a 30 minutes or 45 minutes gap. And they don't want to flood the place with appointment because of data errors. So in the event where you have 10 minutes appointments, regardless of what you use, you are going to have useless data, because if you are using paper, you are now allowed to rush and skip a lot of things just so that the clients can go. And then at the end of the day, you are doing the work, but there is no data to support the work you've done because you did not record everything. You were concerned about the client spending 5 minutes. So it has to be, so it has to be a regulation thing where you make appointments, you don't take more clients in a day than the appointments allow. If you want to make a 30-minute spacing between clients, make it 30 minutes, don't overflood yourself. Whatever you do, do it well.
Understood. Thank you. Thank you.
Yeah.
I think that would work out best. Yes, it would work out best. Thank you.
Yes.
Hi, good day. My concern is that we are not working in a perfect setting where we're able to make appointments and have patients or clients come and the schedule is followed. So my concern is, in our clinic setting, it works with the clients, but you make an error, you have to find your supervisor to clear that error, etc. I understand accountability, but is it feasible? Is it working in that setting where you have to touch base with your supervisor to have, to give them a unique ID, to have them clarify the situation for you to continue your work? That's just my one concern. My second concern is with regards to training. I know we all have our different designations and therefore permissions are not allowed for certain things, but for training, would it be okay to have full access, because we do not know who's doctor or social worker when we're in our breakout groups? So it kind of hinders how we progress, because you have to give permission to do this or another. So for training purposes, it would be okay if we get full access, so we'll be able to navigate the system, just for our breakout rooms.
Yes. So I will update after this session today. I will update everybody's accounts to have full permissions. Then, I think initially we were trying to make it as close to reality so that everybody can see how you only see what your job description is. But for the purpose of training, we are going to allow all permissions to all users. Then in the situation of having to touch base with supervisors when the clinic is going on and you have a lot of clients, the thing will tell the program managers or whoever is going to be the supervisor of the system is to make sure that in a particular clinic setting, one person is given that permission to be able to update. So if you have clinic days, maybe one of the clinical care nurses or somebody there will have that permission to be able to correct errors when they go on. The supervisors can still see the log of who changed what at the end of the day, but it will be easier. So based on the country's unique situation, during the system configuration and users account settings, the super user or the program manager should decide how they want to solve the unique situations. The system will allow anything they come up with. So if they come up with the rule that they will give everybody in the clinical management, on the clinical management team, access to change security things or do supervisory work so that things can flow, they can do that also. So does that answer the question?
Sounds good.
Okay.
Sounds good.
All right. So any more questions?
Not from me for now.
Okay. So if there are no more questions, tomorrow we have central medical stores and pharmacy. Your colleagues who are there, and anybody is free to join if you are free and you just want to follow so that you can see the full capacity of the system, which will help you. Sometimes when you know all that the system does, you will be able to answer some questions that might come up in your mind because you know that, okay, there's an administration permission that allows the administrator to do that. So when you don't see that on your page, you will be able to assume that it's because you don't have the permission and not because the system does not do that. So if you have the time tomorrow, you can join in for central medical stores and pharmacy training, starting from 9. But this is where today's session ends.
I'll join in tomorrow.
Okay.
Thank you.
And for the clinical management team, we will see on Monday for those who will not join tomorrow and Friday.
Okay. I think I can join tomorrow and Friday, I believe. Yes, I can. Yes, I can.
All right. Okay.
Okay.
So I think everybody here today have been introduced before. I don't see any new names, so we can call it a day. And
Mildred, question.
Yes.
The link you send by email, the system, the account. Does it now mean that I can go in there and practice?
Yes, you can go in there and practice.
Practice. Okay. All right. Good. And if we're present on Friday, can we skip Monday, or is Monday a different topic?
Yeah, Monday is a different topic. So if you look at the schedule I sent, so tomorrow, Thursday, and Friday are the same topic. Then Monday and Tuesday are the same topic. So if you can't make it on Monday, you should make it on Tuesday.
Okay, then I'll see you.
Okay, so Thursday and Friday is the same topic. Okay, so
yes.
I can join tomorrow. I can join tomorrow.
Yes, you can join tomorrow.
I can join tomorrow. Yes.
And then Monday and Tuesday are the same. So if you go to the schedule I sent, you will see session 1, session 2. So session 2 is a repeat of session 1.
Okay.
Starting from tomorrow. Yeah.
Okay. All right. Thank you, ladies, for all your assistance and patience today.
You're most welcome.
All right. All right.
Okay.
Have a pleasant rest of the day, everybody.
Yeah. All right. Bye, everybody.
Okay. Bye.
Thank you, Lynn.
Bye.
Bye, everyone.
Bye. Have a good one, everyone.
You too.
Bye.
Ciao.
Bye.
Okay.
Bye.